Thank you, Karen. Our next speaker is Dr. Molina Basilio. Dr. Vassiliou is a surgeon and an educator from the Department of Surgery at McGill University, and she's been very involved in the validation of the metrics for both the FLS and FES programs. And she's going to help link the measurements in the simulator to the measurements in the clinical environment.
Thank you, Jerry and John, for inviting me to give this talk today. And thank you for everyone for being here. So I'm going to talk specifically about trying to link some of the stuff that's been done in simulation to the clinical environment, or the data that's out there, perhaps with a little bit of a focus on FLS and FES, but I will take a little bit more of a broader look at some of the work that's out there in terms of transferability of training. I have nothing to disclose. So, kind of makes sense. I think that most medical students have spent a whole lot of time tying knots on their scrubs or in these sort of very low-tech simulators, and I don't think it takes a whole lot to kind of prove that there is value to this. But this may have required a little bit more convincing, and certainly some of the other VR simulation models that are out there may need a little bit more data. And so I will try to present to you today in a relatively brief format some of the data that's out there for transfer of laparoscopic skills to the clinical environment, and in particular to FLS. And again, review some of the transferability trials for flexible endoscopy and simulation, and show how we may link those to FES. And then some thoughts about how we can move forward with trying to demonstrate transferability and develop simulation platforms for education. So we don't have a lot of trouble now demonstrating that simulation practice improves performance in a simulator, and there's lots of data out there for that. Nor do we have a hard time demonstrating that simulator practice improves performance on other types of models, either live animals or inanimate or cadaver type of models. But the clinical environment takes on a whole new level. And it's a relatively new field that's been growing over the past decade or so, I would say. And there's been a recent meta-analysis which looks at data up until 2006, published in the Annals in 2008, and a Cochrane review looking at VR simulation and transfer to the clinical environment. But it's not an easy thing to do. These studies are few in number because they're difficult to do, and we're always limited by the fact that we have to put the patient first. It's a challenge to control a lot of the elements in the clinical environment. We have to get ethical approval. What about biases of scheduling and other issues related to surgeon variables, how surgeons like to teach, who's doing the assessment, and also motivating residents to participate and comply with our sort of simulation curricula. And this is a table out of, Sean Suda wrote a review, an excellent review actually, in Current Problems in Surgery in 2009. It's just a table showing some of the challenges that are out there with regards to trying to do some of these transferability studies. Issues related to study design, and whether it's appropriately powered. Do we have enough subjects? Did we test them at baseline? What did we test them in? What kind of simulator program? And then issues of training. What kind of curriculum do we put them through? How many hours? Were they proctored? Were they not proctored? And what kind of simulator did they use? And what kind of clinical experience did they have while they were doing the simulator? And what was the timing of all of this? And then, of course, having assessments that are measuring the outcomes in the operating room, or measuring things in the clinical environment, are also very difficult. They have to be validated. Were the trainers trained? Were the raters blinded? Was it live? Was it videotaped? I mean, you can just imagine the amount of variability that can go into some of these studies. And so even though there are quite a few studies that have been done, even trying to compare those with each other is difficult because of all of these issues. So part task trainers have actually been most commonly tested type of simulations in terms of being transferable to the OR. And the first one was done by Dr. Scott, who I think was on this panel, or I missed a part of this. So and he basically tested in just 5 hours in the simulation lab on video trainer exercise, and was able to show that there was improvement on lap chole. And then the famous study done by Neil Seymour in 2002, sort of the VR to OR study, was the first study that kind of brought about this idea of a curriculum that was proficiency-based, or trying to train residents in the lab to proficiency levels, and that it was less of a time issue and more of a proficiency issue in terms of having them achieve some sort of level before they can then do something in the operating room. And they did show that those residents made more errors in the clinical environment. And then there's a whole slew of other studies, but I'll tell you a little bit more in detail about the study that we did about FLS, which was published in 2010. So before doing this study, it was important for us to have an outcome measure that was reliable and valid and specific for laparoscopic surgery. And this was the goals, and I think quite a few people spoke about it already, and I won't go over it in detail, but it's a validated outcome measure that allowed us, after we had that outcome measure, to develop clinical benchmarks. So not only were we able to say, okay, in FLS, we know that a PGY 1 or 2 performs at this level, a PGY 3 or 4 performs at this level, but we are also able to say benchmarks for how people performed in the operating room, and this is specific for dissection of the gallbladder from the liver bed. And you can see there's quite a nice correlation between FLS scores, and if you know someone's PGY level, you can pretty much predict how they will perform in the operating room, and this is, I think, quite powerful. And so once we were equipped with these tools, we were able to do a study, so having a validated outcome measure, a proficiency-based curriculum, which we heard all about. And so we had 19 residents that we randomized to a proficiency-based curriculum. They all had baseline testing at the beginning, so proficiency-based curriculum, or compared to their normal sort of clinical training, and then tested them in the operating room after that again. And so you can see here, this is the results on the simulator. So people who practice on the simulator got better on the simulator. On average, it took them about 7.5 hours to reach the proficiency goals, and about a third of that time was proctored. And so you can see here, at baseline there was no differences, but the FLS trained group improved significantly more than the control group in the operating room by 54%. So you can see that they accomplished in 7.5 hours of training on the FLS simulator, they were able to perform at the level of a PGY 3 or 4 resident as opposed to the level of a PGY 1 or 2, with very modest improvements that we saw in the control group. So this brings along the idea of sort of the pre-trained novice, and there are some people who are looking at this as well, that perhaps it is only, and to a certain extent, allowing them to acquire a technical skills that better prepares them to learn and sort of frees up some space in their brains to do other things and listen to other things in the operating room. But this is, I think, pretty impressive findings for 7.5 hours of training. And this brings along sort of this, and I apologize for the picture covering up some of that Mac PC thing, I think. Raj Agarwal and the folks at the Imperial College kind of introduced this idea of a transfer effectiveness ratio, which really comes from the aviation industry. And it's a way for them to kind of gauge the effectiveness of a given simulator for pilots. And they pretty much like to have a transfer effectiveness ratio of about 0.5, which means that every hour that you practice in the simulator, you can achieve proficiency quickly, more quickly in the real world, so you can achieve it in the real world in 30 minutes. And they did a small study where they actually measured this, and it was a study, like a simulator study using proficiency-based stuff on a virtual reality, and the testing was done on a cadaver, but they were able to show that the transfer effectiveness ratio was 2.3, which is, I mean, even higher than any aviation simulator out there. So again, this is not in the actual clinical environment, but there's definitely transferability of the skills there in a meaningful way, I think. Very quickly, so procedural simulation. So all these studies that have been done up until now are really focused on mostly part task trainers or fundamental skills, quite similar to what FLS is. And there's very little literature out there focusing on trying to simulate entire procedures or parts of procedures. But the data that is out there, so in 2001 there was a small study done by Hamilton, and I think Danny Scott was involved with that study as well, looking at sort of a latex TEP hernia simulator, and they did show the transferability. Again, there was a VR study done looking at the lab Coley module and the lab sim that showed transferability. And a recent trial, actually very nicely conducted, randomized controlled trial in the gynecology literature that showed that a proficiency-based curriculum on a VR simulator transferred very nicely to the operating room. And there's a lot of ongoing work on this in the urology world as well. And I think this is probably the next step in terms of trying to increase the complexity or trying to increase sort of what we can do with simulation. And in their systematic review, the one I referred to, there's sort of, the conclusions essentially were that simulation in a simulation-based training environment is transferable to the operative setting. And obviously the studies were of variable quality and use different types of training methodologies, which makes it difficult for us to interpret the strength of the conclusions. And like many studies or like many reviews, and more studies are required to strengthen the evidence. We're going to change gears a little bit to transferability of skills in the flexible endoscopy world. And this has been a little bit more difficult to demonstrate, I think partly related to the fact that most of the simulators are virtual reality platforms, and it's been, I think, a challenge to try and develop metrics for these platforms that are reliable and valid. And again, the same types of problems occur. The curricula are variable, and the outcome measures are variable as well. Probably the biggest study out there is by Cohen, where they actually randomized 45 GI fellows in 16 different centers, and they followed them over 2 years. One group trained in the GI Mentor for only about 10 hours, and they rated their first 200 cases. And they found actually an improvement or an effect up to 80 cases. And they basically concluded that the virtual reality training, so the 10 hours that they spent in the simulator, was equivalent to about doing 20 cases in the operating room, and kind of concluded that maybe it wasn't worth the investment in such an expensive simulator. And then a more recent study published in 2010 used actually the scope guide system. So they actually trained a group of novices, so they were like had zero endoscopy experience, and they put half of them through a group of scope-guided VR, so the new Olympus simulator curriculum, and then half of them through just clinical, they had to do 8 colonoscopies that were proctored and sort of with clinical training. And then they had them perform on 3 colonoscopies, and what they found actually was, so they tested them both clinically and on the simulator at the end of this curriculum, and they found that the simulator group definitely outperformed the clinical group in the simulator environment, and that actually both groups performed equally well in the clinical environment, so that those people who had trained just in the simulator performed just as well as people who trained in the simulator environment. So interesting stuff to follow. And again, they used the scope guide both in the clinical and in the simulated environment, so this is different. I don't know, a lot of people are not actually using the scope guide, but interesting study nonetheless. Bottom line for flexible endoscopy, so we run into the same methodologic problems. Small studies, different variables, different outcome measures. Virtual reality seems to be the most popular, and so some people have looked at other models, so the explanted pig stomachs or bovine colons and things like that, but in general those things are quite messy, and you have to clean the scope and you have to reprocess it, and it is a little bit difficult to try and do that on a regular basis. And what we found is some of the metrics in the simulator we have to kind of retool them and try to understand which of those metrics that are come out of the simulator are valid and reliable, and which are the ones that are meaningful from a clinical point of view. We definitely see that most of the studies that have been done are really on pure novices, and that it helps to transfer that learning curve or that steep part of the learning curve out of the operating room. But the skills do transfer, and I think that from the data seems to be quite clear. And I think many people have mentioned this, but so part of our thinking in developing the FES program is that, well, we need to have a reliable and valid clinical measure so that we can demonstrate that there is transferability, so that if you pass the FES, both cognitive and technical skills component, that also translates into performance in the operating room. And we've developed and validated as part of the FES task force these valid and reliable instruments called gauges. And if anyone is interested in using these or in having these, they're readily available, very quick to complete, and I think provide residents also with some useful feedback. And we did try to look at this in terms of, well, does a gauge score help us to decide sort of when a resident will be competent, or when does that learning curve sort of plateau? And again, the gauges is really meant to assess competency, and it's not meant to assess mastery level skills in flexible endoscopy. But we saw that for upper endoscopy, the curve as measured by gauges, so that sort of competency curve seems to plateau at around 50 cases. And that for colonoscopy, it seems to be around 100 cases. Again, a little bit different than the recommendations both by GI organizations and by the ABS, but I won't get into that. I think John already did. And so, is this the Holy Grail, however, or is this really just the tip of the iceberg? And I think that the work that's been done up until now definitely proves that technical skills training on simulators transfers, or part task trainers seems to transfer to the operating room, that it's very effective for novices. But it is really just one snapshot in time, or most of the studies that have been done look at sort of one training program and then one, a procedure afterwards, and we don't really know how that evolves over time. And it is, all studies are really done simulation training compared to sort of no training or the regular residency. And we're sort of starting to see that we're sort of, simulation is here, we're already integrating it now, and we may be now trying to get to the next level of how best to integrate these things. And none of these really have managed to look at what the impact is on patient safety, on clinical outcomes, and how we should best implement these strategies in our curriculum. And I think this is sort of the next step for us. You know, the real world is much more complex and integrated than all of these environments. And of course, in order to demonstrate transferability, in order to train these things in the lab, we've broken them down into little parts, but ultimately, the learners really have to synthesize and integrate all of those parts together. And I think that's our challenge in simulation as well. But again, I think that partly, if we can get them over some of the technical skills barriers at the beginning and sort of prepare them, sort of like Karen said, kind of get to the ground running, then they can make the most of their clinical experiences, both in the operating room and in the endoscopy suite. Other things to consider, so again, I mentioned this sort of cognitive load study and the idea of this pre-trained novice, and Theodore Grantrov's group in Toronto has recently done a study where they actually tried to demonstrate this concept of cognitive load, and there have been other people who have tried to actually look into, well, if you can train on a simulator and acquire some of the technical skills, does that free up some space for learning or for doing other things in the operating room? And they did show that residents who trained on a simulator for a fascial closure actually retained more. They got the clinical teaching and other information when they were in the operating room, and they tested them again on their retention afterwards, and the residents that had had simulator training just for the technical skills component retained some of the other cognitive stuff that was happening in the operating room. And other things, so judgment, troubleshooting, other types of knowledge that are essential to a general surgeon. How do we integrate that into simulation? And that simulation is really an ongoing process that, although we want to, the FLS and FES programs are benchmarks, that there is a role, I think, for ongoing simulation after you've had experience in the clinical environment, had the opportunity to recognize some of the weaknesses or areas where you need practice, then to go back to the simulator lab and work specifically on those things, like in a sort of deliberate practice model. And there's more and more focus now on the non-technical competencies and how can we integrate those into our simulation programs. How can we make simulations more complex and involve more higher level trainees, even practicing surgeons, or for maintenance of certification. And there is some work going on as well on using simulation as a warm-up prior to the operating room. And Theodore's group as well has a small study where they actually showed that warming up does increase your performance in the operating room on a lab chole, but very, very small study. And I think I pretty much mentioned most of this. And for the sake of time, I will move on. So in summary, practice proficiency on FLS and other PARC task trainers improves clinical performance. I think that's pretty robust. The data certainly for FLS are quite robust. For flexible endoscopy, I think using some of these virtual reality platforms, at least a proficiency training, is of use, but we still have to work out a little bit some of the details on the metrics and so on. And keep in mind that a lot of these have focused on technical skills, and PARC task trainers, the effect is most notable for novices. The data are heterogeneous and difficult to compare, and we still have some work to do in terms of defining best practices for implementation. So I think there's no question that FLS, well, you have no choice. FLS is pretty much required. And I think soon FES should be a requirement for all trainees. I think the idea of doing it beforehand is an interesting one, even though it wasn't designed in that way. I think having them do it before they actually go to the endoscopy suite would be interesting. If FES could be coupled with a training curriculum for the technical skills as well, because keep in mind that it is more of a, at least the cognitive component is a training program, but there is no sort of a simulator-based practice component, so that still needs to be developed. And we need more large-scale studies, collaborative efforts, and to try and sort of be on the same playing field, use the same outcome metrics and curricula. That's all I got.
Thank you.